Hello and welcome to the Days of Learning podcast. I'm your host, David Nelson, and it's so good to be here with you today. The Days of Learning podcast is the podcast where we just discuss health, wellness, medicine, and community engagement. The Days of Learning podcast is brought to you by the CDC, the Wisconsin Department of Health, the Milwaukee County Organizations Promoting Prevention, and the Medical College of Wisconsin. I am so thrilled today to have Dr. Syed Ahmed as our guest. Good morning, Dr. Ahmed.
Good morning, David. Good to see you again.
You know, I could spend nearly the whole time talking about your bio and your background, and I won't do it. We'll get into that in a little bit, but I want to tell the audience a little bit about you before I ask you my first question. Dr. Ahmed is known nationally and internationally recognized for his contributions to the field of community health, community academic partnerships, community-based participatory research, and community-engaged research. He has been an invited expert on community academic partnership and community-based participatory research at the Agency for Health Research Quality, AHRQ, the Center for Disease Control and Prevention, the National Institute of Health. He was a member of the Council on Public Representatives, COPR, an advisory board to the NIH director and the co-chair of the COPR's role in the public and the research work group. That's a lot, Dr. Ahmed, that you've been involved with at a national level. But before we get into the national scene of community engagement and what you have done, I want the audience to learn a little bit about you. Tell us about you and how you came to your current position.
Well, very briefly, I'll go briefly. So I'm a physician. I think that's my profession is. So I came to Houston, Texas, some 30 plus years ago, where I did my residency and fellowship in family medicine at the Baylor College of Medicine in Houston. And also got my master's and doctorate in public health at University of Texas in Houston, School of Public Health. After getting my education done, I came to Ohio. First, I practiced in a rural area for a couple of years, and then moved to Dayton, Ohio, where I got first academic job as assistant professor in Rice State University in Dayton. I stayed there for many years, actually started developing many community engaged programs there first. Then came to Medical College of Wisconsin about 20 years ago as an associate director for Center for Healthy Communities in the Department of Family and Community Medicine. Then I became actually director next year of the Center for Healthy Communities. And then we actually combined the Center for Healthy Communities and the Research Division to make it CHCR, Center for Healthy Communities and Research. And I directed that also for many years. Then I moved into the Medical College institutional program, and I became the Associate Dean for about a few years. In 2008, Medical College first had community engagement as a mission, one of the 4 equal missions. Other 3 missions being education, research, and clinical care. So community engagement became the new one. But the Office of Community Engagement, the Senior Associate Dean of Community Engagement, was not established till 2012. So I became the inaugural SAD for community engagement. I'm still holding that position. I also hold the position of Associate Provost. That is a new position for community engagement also that was established about a couple of years ago. So this is very brief summary where I started, where I ended up.
You know, I appreciate you telling me that the more recent lineage, but I want to go back because I think this is a fascinating story. Tell us about how you became a physician, how that journey, what instilled with you to think about medicine as a career path.
Actually, medicine as a career path was, I think, not as surprising for me because of my family lineage. So I born in Bangladesh. In my family, there are many physicians I grew up with, from brother to aunts to uncle. You can ask for it. So I saw them growing up and got very interested in medicine when I was young. And I used to listen to their stories because when you have three doctors, they usually chat about many things. And those are very fascinating to me, the people taking care of people and so many things they see. Every patient is different. Even when I was young, I got a good sense of how physicians work with the people. And by nature, I enjoy story part, knowing people's life. Those are the kind of things I always had significant interest in, especially the literature part, art part. Those things all really started making sense when I started listening to my brother talking about it, my aunt talking about it, my uncle talking about it. Those things interested me. And when the time came, I went to medical school in Bangladesh, Dhaka, and got my education. But then I had wanted to get higher education. And that time, actually, in many member of my family were physicians, went to England for higher education. I was more exception. I loved America. For some reason, I started knowing about it more. And I thought this is the most advanced country in terms of healthcare. And if I have to go somewhere, I would rather go to the best place I thought. And that brought me to actually Houston many years ago. So that's I think, a simple way I can put it. It was not like a major light bulb went out of, I think, happened in my head or anything in that kind, but it is more connected to what I saw. One thing, however, it was not that the family pushed me to become physician. That was not even the case in my case. I wanted to be physician because I thought it will be fun. And actually, I still do it today after 40 some years. I think being physician is actually fun. At the same time, it is a huge responsibility. And if you are a good one, you actually enjoy it.
What did your family think of you going from Bangladesh to this place called Houston?
Yeah, that's a tough one in a sense, because as I said, many of my relatives or even other people, even my brother and everyone actually used to go to England, London. And I had lots of connection with the London, but I didn't have too many in America. But because of my interest, I came, and it was somewhat scary. My sister actually was in Houston briefly when I came in. So there was somebody there when I came in, then they left. So I was on my own for quite a few years without having resources actually to get all the degrees and everything I'm talking about. So I had initial lots of challenges, not knowing people, a new town, new country, new state, everything you can think of. But now looking back, I think, as people say, the comedy is tragedy time removed. So all my tragedies are now comedy. I enjoy even thinking about those early days in Houston.
Okay, Dr. Ahmed, I got to ask you, you went to Houston where there's some world-renowned medical centers. You got multiple degrees, public health and a doctorate, and you're just in the mix of medicine. And then you end up in rural Ohio. What's up with that?
Yeah, that's another one. Changed my life in more than one way, I thought. So after I finished all the education and, as you said, and training in Houston, I moved to a Appalachian town in Ohio of 1,500 people, very rural, very poor, mountain, and very beautiful, all at the same time. So when I arrived in that town, I don't think people in there even saw my color before. There was no Asian people in that town, this Appalachian town. So I was completely unknown to them, and as much as they were unknown to me. And I didn't actually know the word Appalachian before I moved in there. So this was a very different place, and very quick short story. The first day I arrived, early in the morning, driving a big truck with my wife, we got lost in that small town, not knowing where we are going. And actually, we found a policeman sitting beside the road. So people usually like to avoid police. In this case, I actually went to the police and asked him about the address which I was looking for. The policeman talked to me, smiled, And then he extended his hand and said, "You are Dr. Ahmed, you are coming to this town. New doctor, right?" I smiled and said yes, and I was surprised. So when I got into the car, my wife said, "He looks very friendly." I said, "Yes, not only that, he knows my name and he's going to take me to our house." So that was my first introduction in a small town of this beautiful town in Appalachian Mountains. So in that town, actually, I learned very different medicine. So when I say the Baylor College of Medicine, I learned different kind of residency program, which is very subspecialty oriented. Basically, if you call for one cardiologist, you can get 100. And in this town, there were none, not any subspecialty. There were only 2-3 physicians in whole town. And the clinic I started was just only another physician there. That is another story how that changed my life. So that's what I ended up, stayed there for a couple of years.
There are stories within that, and we won't necessarily get to all of them today. You know, I think you give a good example there where the police person extended his hand and he said, "Welcome, Dr. Ahmed." It's a good testament, and maybe it's symbolic of your work in community engagement. Tell us how you got started in community engagement, and was it an easy path? Did everybody extend their hand?
No, not at all. And I'll tell you, David, you most probably know, even to date, the path is not always straightforward. It has lots of bumps. But I have to go back when you ask how or I started in community engagement. That's another short story. I might have said that before, but for this audience, let me say it again. So in that town, I found out that they have a huge cardiovascular disease. They are the highest in the county in Ohio, and maybe one of the highest in the country. So because of my background in public health and my thesis on the cardiovascular risk and high cholesterol, I thought I would started creating a program for this community, for this town, so that I can affect their cardiovascular health. I had actually good time, plenty of time in my hand, in the sense in the weekend I was free and my wife was getting her PhD, so she was busy and we didn't have any kids then. So what I did in the weekend, I created a whole module of how to affect cardiovascular risk using my public health background. And I am new in this town, so I didn't know many, but my nurses came to know me very well. So one of the nurses had connection with some community group who meets usually once a month, and it has a title of some sort. And she said, "Why don't I take you there, and I will make sure that you get to say a few things about your idea. Maybe people get excited about your idea." So that was my first interaction by myself with a community setting. And there was about, I believe, 30 to 40 people in that group. And I was given about 10 minutes time to talk about cardiovascular risk reduction in that town, some ideas I had and how to do it. So after I presented that, and I asked for anyone have any questions, I was standing in there. Nobody was raising any hand. And I was standing in there thinking, maybe I didn't get across, maybe they don't like what I said, maybe something. I was just really hoping somebody says, "We don't like the idea." That would be fine too. But nobody was saying anything till a young woman raised her hand. And I looked at her and I said, "Yep." And she said, "Where can you buy cheap diapers?" And I was stunned for a few seconds because I didn't have a kid to know about diapers. Then I thought for a few seconds, maybe diaper has some relationship with cardiovascular disease, which I didn't know. But anyway, I got my wits back. Then I looked around the room. I saw most of the audience were women. So I looked at the room and said, "Do any of you have answer to this lady's question?" And immediately 2-3 hands went up. And the next 5 minutes, they all started talking about diapers, what to do with cheap diapers. That was my end of cardiovascular risk reduction. So, but I came home. Then I started thinking about that, I took about a year developing it and people didn't want to even listen to it. So what are the problem? So in my science aspect, I was pretty good, knowing what to do and how to do it, but there is something missing. And to make very long story short, I started reading some literature. That is the first time I started coming across something called CBPR, community-based participatory research, community engagement, and those kind of literature, which is actually was not taught in the School of Public Health or never was even discussed in the School of Medicine. And I started finding out there are some different way to address this kind of issues with the community. So I also figured out the mistake I did is few. One is I didn't know the history of the town. This town saw at least 2-3 other research groups came from Cincinnati, did research and left them when the research was done. Didn't even give them a report. Second thing is I didn't know that it was a tobacco producing county. People were very poor and their livelihood depended on tobacco production. And out of 10 minutes, at least I took 4 minutes talking about to quit tobacco. So I was right on my science aspect. I didn't know the social impact of for them that is the livelihood. And third thing I didn't know is I didn't know any community critical person, key person to know, community leader, or I didn't get them early enough to get their input. And fourthly, I would say the biggest challenge is, again, I developed all the ideas sitting by myself, giving my own time. I involved nobody. And I figured out when I started reading literature, this is the reason I failed. So that stayed with me. And then actually I changed my whole process when I moved to Dayton to Wright State University, learning from the CBPR language and literature, joining many of the national group where they talk about CBPR, but that was very early days of CBPR.
I got to ask you if you can remember, and you have told me the story. What was your first reaction when she said about the diapers? What did you immediately think?
I cannot recall. I was stunned to begin with. I was a little bit puzzled. And first I thought about, I have to answer her and I don't know how to answer. I never actually had seen a diaper, but I never used one. We didn't have a kid, but I immediately figured out there is maybe something I'm missing, that is a young woman is asking where you can buy a cheap diaper. That gives me now, looking back, the poverty and social economic challenges some places have, that even buying a cheap diaper is challenging for a young mom. So I think some of the things all started going through my head in some vague way. And I at least got my wit back when I asked other people to answer that question. So it was a very mixed reaction. At the same time, I was a little bit unhappy, I would say, that after using all my time and try to come up with a good solution, quote unquote, for them, nobody really was interested. So I learned also one thing long time ago: don't do for them. Don't do for any community partners or community people. Never. That's the wrong approach. We learned long time ago also, do with them versus for them. And this was perfect example of, for me, developing a for them project.
Syed, I want to ask you, because you said something that I want you to go a little bit deeper on. You said the phrase social impact. And I really want you to take us down this path as a trained physician, as a scientist who tries to deconstruct and figure out what's going on. How do you connect social impact to medicine and science?
I would say we don't connect it. That is the biggest challenge. So let me go backward a little bit. The critical attributes and of community engagement, I would say, to the literature and to the health of our country is the critical understanding that community's health is not dependent on completely on what hospital or your healthcare system does.
Mhm.
This knowledge, actually, many of us who has been doing community engagement for 30 plus years already knew about it, because through the literature, it started making very clear the social determinants of health, economic determinants of health has significant impact. About 10, 15 years ago, when Robert Wood Johnson Foundation and some other universities really counted the numbers and the process to figure out what is the contribution of social determinants of health and their outcome, they came up with about 80% of your health outcome is connected to social determinants of health. Only 20% is what we do in the hospital setting or our inpatient outpatient setting. So as a physician, some of the things we knew, we never talked about it till about a few years ago, people started understanding the value of social determinants of health. So give an example, in my patient group, over the years, I have many people rich, many patients very poor. With the same disease and diagnosis, I have to always think about what medicine I can give a patient who cannot afford or who doesn't have enough money for medicine. And I have stories after stories how people do not take their medicine because they cannot really afford it. This is not one time, many times I have seen it. So I'm just saying, even in the hospital system, the understanding that there are some other factors which lies beyond the hospital system, which has far more impact on the health of their patient and community, was not really a common knowledge. This is very new knowledge. For the first time in my lifetime, in our computerized system, now we started looking into social determinants of health, meaning that do you have food, do you have a housing, those kind of stuff. But I would also at the same time tell you, David, we still do not have good way to do anything about it, follow up anything about it. We started just understanding the value, the process, how to deal with it to make an impact is still not there. So this is my reason is when I talk about sometimes the American healthcare system or outcome wise in America, in the whole world, usually around 36, 37 place in terms of health outcome. We are the most advanced country. We spend more GDP money than any other country or many other countries combined. Why we do so poorly? A big factor, significant factor is we do not address the upstream factors of social determinants of health, economic health. We do everything, we spend all the money in where the impact, possible impact is only on the 20% of your health outcome, which is the health system, hospital system. We do a great job. I would say we are most advanced there. But if I have an advanced thing, my patient cannot even afford a medicine. It doesn't really matter how advanced my clinic is, how advanced my practice is, how skilled I am in advanced care.
So, you know, it doesn't take advanced degrees to know that if you live in substandard housing, your health is going to be impacted by that. I don't want to get political, but what needs to change if we're talking about these upstream factors that are affecting the health of the entire community, correct? Mm-hmm. What needs to change?
I think there's not only one thing that needs to change. There are too many things, but two big things I would say right away, without, again, like you said, going to politics and policy. Those are the two P's affects our health outcome significantly. So yes, politically, we do many things which doesn't serve well everybody's health, our community's health, people who suffered more than any other group. People of color in basically every town has worse outcome than anybody else. So there are lots of underlying factor, politics keeps it going, which is there. And policy-wise, which is also connected, both local policy, national policy, those things has to address it. knowing a problem and not doing anything doesn't do anything. Meaning that your diagnosis of a disease, if I just diagnose somebody's bad disease and I decide not to do anything, if I had a process of doing it or he had a chance, but I decided not to do anything when I could have saved somebody's life, is a major disservice. So what I'm trying to say is more and more people, even the politicians, started knowing the impact of negative social determinants of health, health disparities, lack of health equities. These are becoming common knowledge. On the other hand, there has to be a strong will that go beyond politics and come up with the right policy to make it happen. Third thing I would say is community has a big role. Communities, I think over time, I feel a little bit enthused about it. They are becoming more educated, maybe more savvy. They're understanding their problem, but they have to come together, really pushing this both policy and politics, those two domains that will be helpful. They cannot stay quiet. Now, what is our role as academic? This is the other area. So academics like you and me have been working in the community basically whole academic life. And we did it or do it for the reason that we genuinely believe that we need to change what goes on. Otherwise, there'll be no improvement in health outcome. We can say all we want. If housing doesn't improve or people are still food insecure when they go to bed at night, well, I can do all good thing I want. It don't want to work. So academic in the community engagement world has been the forefront who have been working with the community in a genuine fashion. That's the underlying reason to do community engagement. It is not a research for research sake. It has social value, and that is the reason people get interested. It has challenges many different ways, but I think we do it, we're supposed to do it for the right reason, partnering with the community and pushing the boundaries, pushing the politician to go do the right thing, and encouraging or working at the many different levels, state to national level, to change policy. So lots of people has to do many things before we see an impact. And I don't think we are even close to that.
You know, you really give us, you brought that idea of social, and you said social value, and earlier you had social impact and the social determinants of health. You mentioned that there's a greater awareness at both ends of it, both from the medicine, the research, and the community side of it. What has changed in the time that you've been in the field?
Some of the things I would say changed. Many things has not changed. But as far as for example, the science aspect, let me come from the academic end. The science aspect, the community engagement was not existent in medical school even 30 years ago. When I started in the right state, nobody knew what CBPR was. When I came to Medical College of Wisconsin 20 some years ago, only 2-3 people knew about community engagement. Didn't mean they were doing anything. Some of them may be doing a little bit. So there are, if you now look forward, like Medical College, many other people has started getting interested, understanding the value of community engagement, they started learning about it and trying to practice. Not a huge number, but far better number. Now you have some friends to work with. There was a time it was a lonely job in right state, or even when I came in here, it was a very lonely job. I used to go to different places to find people who are doing community engagement. And it was interesting. There was no community engagement, or very little or none. That way, I would say, at least in Medical College, there's a huge changes. We are one of the only few schools who has a full mission of community engagement. And I would say nationally, because I have lots of national connection, many other medical schools has embraced community engagement. On the community side, however, communities, I think in the past, let academic come do research and let them go. And now I believe there's some accountability. Communities are getting savvy, and our job is to actually work with them so that they also see their participation is valuable. So community engagement principle has to respect both communities' expertise and your expertise. It has to be taking roles and responsibilities seriously and have the equitable power and responsibility when you do community engagement. You get community involved from the very get-go when you start a project. You stay very respectful, have a bi-directional dialogue all the time to make it happen. So some of the things communities are also learning because of some of the work, David, you have done and some other people have done. They're learning that academic cannot just come and do things and leave. And they need to hold us responsible. Now, so there are some pluses. I'm always looking for pluses, but there is many gaps. And I would say gaps exist in the academia that many people still do not understand community engagement. They don't understand the principle and values. Sometimes even if they understand, they don't follow. They don't know how to practice. We still send people to do community engagement in the community without training them, educating them. Some of them think they don't need any education and training. They know what community engagement is. So I always bring up saying that in the medical college, you cannot expect we can send somebody to a lab to do a rat research without training them well. 2-3 years you get trained. We don't hesitate to send faculty and staff and the students in the community without getting them trained well. This is an art and science. It doesn't really, you do not get it by diffusion. It has lots of learning behind it. So some of the thing has changed, but not completely. There are still challenges in the academic end. Other thing, if I just want to mention is, one thing I would say academia has avoided, and I think you most probably know that very well. The academia as a whole avoided addressing the impact of racism in our lives, in the communities, in the whole country. We knew it, we know it, we avoided it. We didn't want to talk about it. So if you ask me some changes, I would say recently, for the events you already know, this is the first time in my lifetime, actually in my academic lifetime of many years, I see people are talking about racism a little bit more openly. And this is a good start. Talking is one thing, doing is more important. But I would say even the talk and discussion was avoided by everyone because they didn't want to touch it with any pole. And the impact is racism exists, making negative impact on our lives of our citizens.
Dr. Ahmed, thank you for that, that notion. I do want to ask you though, because I know the story and I think our audience would appreciate it. We do like to have a little bit of fun. So you talked about training, right? And you talked about if you went into the laboratory with the animal studies, what would happen if you were doing studies with the rats, Dr. Ahmed?
I can guarantee by the morning, all the rats would be dead. I would be very bad at it. So I know my limitation. So I tell people that, I know my limitation and people should know their limitation. People should not just automatically think that they know what they are doing and they're doing the right thing. So to me, people need to take community engagement a little more seriously than just saying, I know community engagement. It takes many years to understand the principle and values and practice it. And you have to do this really in the real world. Reading books on community engagement would do you no good. You may learn few things, which is fine. But when you really practice, do few real community engaged research projects in the community for a few years, you'll learn far more. You'll find the trial and tribulations and the challenges. You'll find out that community engagement never goes in a straight line. God knows it has ups and downs. Those are the kind of things I think people know only when they get immersed in the community. So I think those are the few things needs to be trained and missed. So when I say people needs to get trained, that's basically, I mean, not only theoretical didactic training, but practical understanding. Work with a mentor. Like you have many mentees you take with you. That is critical. They'll learn far more from this. And even with some plus minuses, sometimes we get challenges and every project is different. But some of the values and principles, those are fundamental. People has to practice it.
And they haven't changed. And I could say with a great deal of certainty, Dr. Ahmed, that you have shared with me that unless you're having challenges, you're really not doing community engagement. But I
Exactly.
do want to ask you, because you said a word that I had never heard you say before. You said at times community engagement was lonely. What kept you going during those times when you felt alone? Because I frankly know that you like being amongst people and you're a very social individual. I've never heard you say lonely before. So what during those times kept you going?
So those are my early part of my life, I would say. First example, in Wright State University, when I went there as a new academic, I started going around in the community and trying to understand what is the community is doing, what are the needs and resources. And I didn't have any grant or funding. It was more going around. And if I can tell you a short story, actually one time my that then chair met with me, and God bless him, he passed away. So I have lots of respect and rest in peace. But he invited me to talk to me that why the heck, what I do in my 20% or 30% time of research. And I told him that I go to the community, different events and try to understand, and I'm looking for some project to do. And he said, what does all this mean? So I tried to explain to him, this is the way CBPR is done, community-based participatory research is done. And he didn't understand any word I said. Then at the end, he said, well, Syed, whatever you do is fine, but I'll tell you, you'll never get promoted to associate professor if you keep on doing what you're doing and not bring money, get grants. Anyway, those are the times there was not a single person who actually was my partner. It was more basically me going around, quite lonely and worried. Why I was doing that? Because as I mentioned, in the rural part of Ohio, when I learned that my community engagement, the way I engaged the community didn't work, I was learning at the same time that how CBPR works, community engaged research works. And those are part of the thing, but I didn't have many people. I had few good colleagues. They were supportive of what I was doing, more as a friend than going out with me. And I would say when I first came in 20 some years ago in medical college, it was not much different. I mentioned that only few people are doing it. I started directing the center, started trying to establish the CBPR project. And I also have been to many places. And I used to, like you do now, God knows, daily out. There was a time I'd be daily out in different places, trying to know people. I was getting connected with people. I started going to churches and the Sunday church, all those programs. And I might have told you that I started joking around that I had been to more African American churches than anybody else in the Milwaukee. And that was partly true because I had to go to make the relationship. And those times, there are not too many people. Slowly, it changed over years. When you started having projects, started getting more right faculty and staff recruited, started training, started doing some fellowship work connected to CBPR, which, David, you are part of it. Slowly, the number increased. But there are lots of time, it was lonely. Sometime in the Sunday when I'm driving to go to a church, it was just by myself. And going there, sitting there, I, of course, tried to know the pastor before I went there, and they came to know me. And or going to some Hispanic center, day in, day out, every week basically, and go there, have coffee or something else. So those are the, I think, significant many years to me was a lonely time. But internally, I was feeling I was doing the right thing. Internally, I had a strong belief that I have to establish the community engagement here in the medical college, and there is no alternative. And over time, hopefully, I will have many people who join this whole concept and practice with me. And that's the reason we have significant number now. So yes, I would say it was far lonely than you think, at least initially. I do not actually feel lonely anymore, thanks to many people I know.
Thank you for that, and thank you for indulging in that. You have mentioned some of the principles around community engagement. You said spending time, going out, participating, collaborating, bidirectionality, listening and learning. Can you give us a framework for community engagement? Because I think everybody lives somewhere, so they could say, oh, I know the community because I live somewhere. Or I volunteer, you know, at a soup kitchen once at Christmas. Am I community engaged? Can you give us a framework for how you think about the work?
I have to tell, this will be most probably 10 hours discussion, but let me just summarize it quickly. So one thing people need to know, the first, what is the common language and definition of the thing we talk about? And that was the biggest challenge in the community engagement domain or the literature, that there are lots of confusion that still exists in some people's mind. But now people clearly define, which has been accepted by NIH, National Academy of Medicine. Right now we are working with them and many other entities, many foundations. So there is a definition of community, very well laid out. The definition of community engagement, definition of community-based participatory research, definition of community engaged research. All these are connected. There's also clear definition that community engagement can be different things. They're not all same thing. Community outreach, community service, community engaged research, community engaged policy work, or community engaged education. You can do many ways that can fall under the community engagement, but the principle that you have to believe in and work on it is not unidirectional. You also do not, so if you started doing some project in the community because you like it, like for example, when I started doing that diaper kind of story I told you, it was my idea, it could be community based, but there is no participation by anyone. I didn't involve anyone. From the concept to the development to the implementation, there was nobody involved. So in community engagement, if somebody wants to understand that, I think there are enough literature is written on the framework that from the very get-go, how you do it is important. You look for the strength of partnership as a critical attribute. Why? Because community engagement is difficult at many levels. Somebody actually once said community engagement is not nuclear science. Actually, it is harder than nuclear science because you can go wrong in many ways for many reasons. So that is the reason developing the strong relationship with the community partner is important. And clearly defining your project is important. Otherwise, everybody will say their project. Does it meet the definition that is already accepted? People have to understand that, look at that mirror and say that. Then you are dividing your work equitably or not with the community partner. You take responsibility, community partners take responsibility. You take credit, they take credit. Don't take all the credit either. So you have to divide them. Even resources, you have to share your resources. Capacity building is important, not for only the academic, but developing the capacity of the community partner. What do I mean by that? Say, if you have been doing a community engaged project in some community partner for years, and after 5 years, their capacity is exactly the same. They have learned nothing. They don't know how to do anything. They have not got themselves moving in from where they were. You have actually not done a major principle of community engagement. I can give you some specific example, but without naming. Like there is some Hispanic center in Milwaukee. When you started working with them about 18 years ago, their capacity was very small. Now, if you go and look at it, their capacity for community engagement and research is huge. So it is not that we did everything, but we worked with them in some level. So they started learning, they started bringing, they have a whole research division for that particular place. So that's I call capacity changes. Same thing for the academic. David, if academic keep on doing community engagement and they do not learn and change their capacity to understand, do it better next time and become proponents for changes in the community, then I would say their capacity is not changing. So academics cannot just take a project, do it, doesn't learn anything, move on. Academic, if you do a project, They need to see some changes. They need to reflect on it. And reflection is critical, as you know, in community engagement. Have I done something wrong or right? I could have done something better. I could have prevented this. I could have predicted this. So those are the kind of things you have to assess it. You don't have to really write down everything, but if you have a diary, write it down, understand, and build on it. So it takes many, many years to start it good at it when you started doing community engagement. That is, I call capacity changes for the academics, just like the capacity changes for the community partner. Another major principle is dissemination. One of the major problem has been in the academic research is academicians has worked in the community in many different shape and form, used the data and published without sometimes telling the community partner, without even giving them any credit, and even you cannot even think of giving authorship. That has to change. And your dissemination has to be both in the lay people and academic peer-reviewed publication, because you have to think about both audience. So some of the things are ingrained in community engagement. So if you look at the CBPR principle and community engaged research principle, they're very similar. Only it says it different way, but they are very similar in terms of basic concept and values. So people need to understand. I cannot teach that just giving in few minutes what are the principles. I think it is, if somebody is interested listening to this podcast, I would suggest, I think, go into the literature or ask us. We can direct you and then see you are getting the idea, at least get the idea. That is the part of the didactic I suggest you do. But that is maybe 5-10% of your knowledge. Then go try to practice it, do with some mentor, work with some project, program, learn. So take it a little bit more seriously than just saying whenever I like this community engagement. And that's my problem is when somebody keep on just saying I'm doing community engagement, who has not done the hard work of doing community engagement.
You know, you really gave us a lot there. And I thought of the image of a coin, and you talked about this capacity building. And if we look at the word engage, it's something more than just going out to, but it's a deeper level of that. And that there's capacity building on each side of the coin. There's building understanding of capacity in the community. You used the example of the community center where they started off not knowing much about research. And at the same time, you learned a lot about that community center and the neighborhoods with which the community is working from. So it really has to be both sides of that. Is that correct?
Absolutely. And that is the critical thing, especially for academics, to understand that value of, so I would say, community knowledge, community expertise, what they get from community. So if I have been to that community, I have actually good sense of certain community I have worked for a long time. And it is not because I read a book on the health of, say, Hispanic population or Latinx population. It is because I have seen it, felt it, learned it on the ground, and what affects the health. So those are the kind of things your capacity has to change. But first thing is, academic needs to understand that we don't control all the knowledge. We may have some academic knowledge, no question. I have, or all of us have a bunch of degrees, but that's not the main thing I'm talking about. Community has some knowledge, which is only they have. And you have to be open to that part, respectful for that part, and use that part for your project, because that is the reason I think it will make a different impact than other projects.
It's a really good answer, and I appreciate that. I want to start to pull this all together, all right? Now, one of our sponsors is Center for Disease Control and Prevention, and we are sponsored by a grant that is trying to prevent type 2 diabetes and hypertension, which you know a lot about. Okay, how do we combine medicine, community engagement, and science to do more with the community around these two chronic diseases? Help us to kind of hone in on that space of medicine and the community to manage this in oftentimes in challenging situations based upon social determinants.
Yeah. So you most probably know, I think, David, some 100-some years ago, that we didn't have the division between medicine and public health. Mm-hmm. It got divided 100-some years ago. The they took different paths. Medicine became very much curative and individual patient, and then subspecialty oriented. Public health stayed in a different arena. There was a time they were actually very close. So what it has done is, again, when I see a patient with the diabetes in the clinic, my focus is extremely narrow. Hemoglobin A1C and this, whatever the number is, blood sugar, and take the medicine. I do not think what is the other factors that is really affecting this chronic disease. Very quick story. There's a woman I have been seeing for a long time. That happened a few months ago. It took a while for me to get her A1C under control. Very nicely controlled, blood sugar is under control. Then I have not seen her for many months. Then when she came in, her number was all again, very wrong direction, all high. Blood sugar was significantly high. So I was a little bit disturbed by that because it took a few years to bring her good number. Now she's back again. So I was asking her, what happened? Did you stop taking medicine, this and that? And after asking her a few different ways, she suddenly started crying. And I immediately apologized to her, saying that maybe I came as too strong. And that came because I told her that you and I have been working on controlling your diabetes so well, and suddenly I see a number has gone direction. So I really wanted to know, and I might have come as a little bit strong the way I asked the question. So I apologize for that. Then she shook her head. She said, no, that's not the reason I'm crying, Dr. Ahmed, and I know what you mean. But the reason my numbers are high is I do not take my medicine every day. I said, why? And then she said, because I do not eat every day. So the whole point is that she cannot afford food every day. So she cannot figure out when to take her medicine or not. So the day she gets some food, she takes her medicine. So anyway, so my point is this. The role for community engagement in all of those things is, maybe it is a connector between this public health concept of the everybody's health and medicine's very narrow focus on individual health. Community engagement is a process which brings these two together, which brings community to really think about their health in a different way. These diseases, diabetes, high blood pressure, they are chronic disease, and many things are very preventable. We know that. And this chronic diseases kills more than anything else in our all the US population or in the whole world. So when people started taking all the other factors more seriously and started really doing things which will impact the health disparity, social determinants of health, economic insecurity, all of those things has to be there. But community engagement is the connector, because people who are expert in community engagement can bring the community people to work with the academics, or in a larger sense, not an individual patient at community level, but this whole area is very health conscious, for example. And that will make an impact on many people, not only one individual patient. So in summarizing, what I'm trying to say is chronic disease is impacted by all these factors, what we talked about, social determinants of health, of anything you can think of, a dozen, and economics. Those things impact your chronic disease far more than you can think. Racism impacts your chronic disease. We know that. We said zip code is more important than your genetic code. And there is some truth to that. There are other factors too. But whole point is, if, again, we started knowing things, we have to come up with the ideas how to address it. Then you will make it. But as the individual physician talking to individual patient, still from time to time, or many times, I do know about my patients, where they're coming from. I look at the chart or some discussion about their food insecurity, for example. I have some homeless patient too. They still come into the clinic. So those are I'm talking about individual physician responsibility. But I think these are the kind of things ultimately in the larger social level work where medicine and public health can join their hand, can make a significant impact. I wish we didn't divide us that far.
Thank you for sharing that story. I think I thought I've heard all the stories, but that was a new one, and I want to honor your candor, and I could feel your emotion, and I'm still emotional over that instance. You know, Dr. Ahmed, I want to ask you though, because we talk about the two-sided coin, the community capacity and the clinical capacity or the research capacity. Can you use this example? What did you tell the woman about how she can support her own health?
You're talking about that woman?
Yeah, or somebody like her, because we want to do the best we can with what we have. And so if there's a role for the community in this, there really needs to be a role for the community to solve this.
Yeah. Well, I think I would say every case is not same also, but that particular patient, for example, what I did is so that, you know, I connected her with the social services of the hospital system, asked her to talk to them in terms of food insecurity, and she also has some housing issues. She also has lack of funding, even or money for, you know, her medicine too. So some of the things, when I say that when you know a problem, if there is no connector to do something, you do a major disservice. In this particular case, at least I found hopefully the right people to work with her. My point is, however, has to be more systemic. It doesn't have to be like a one-on-one. Every time I get a patient, then I have to start running around like crazy to do something. It has to be, I actually talked to some other people in the Federal Hospital and here, that it has to be more automatic. When I see a patient, if I'm looking at the negative social determinants of health, if I know what is going on, it should be straightforward for me to connect without talking to 7 people. That's what affects physicians get depressed when they do not know where to send things. To me, we have enough patients in that group. All different people has different problem too. But why can't we create a system that if I know somebody's food insecurity is a big thing, I click, I give the information to the person, or I make the connection with somebody, and that is taken care of. Why can't we do that? And those are the few things actually I would say health system should spend money on to create it. That will ultimately improve the health of the patients they serve.
Thank you. I appreciate you asking that, because there is a role for everybody in some of this. Dr. Ahmed, as we start to wind down, can you tell us about some of your rhythms and your practices that you use in your own life to think about your work and to think about your research and to think about how you lead other people in community engagement and medicine?
I think over time, I think you most probably develop your own rhythm. I also, because as you know me very well, I do many different things. So I have to be somewhat organized and structured in terms of my professional work. I'm talking about my academic work or professional work. So I also stay focused on the thing I do usually. If I have to do every day, I may have a list. Not every day, hopefully, but I have lists. I have to make sure I get those things done. That is one piece. Second piece for me has been for a long time, I learned that the way people can work better if they can create a academic culture of team. And as you know, the Office of Community Engagement is small, but I always have been very proud of our team. We have faculty, staff, extremely trained and educated and believe in the cause. And my thinking is thinking about everyone as a leader in that team, from a staff to the faculty, and give them opportunity to lead. Most of the time, I think people really take the challenges. Many people have grown their life and career because they were given challenges and they took it and they really worked it. And my job as the head of the Office of Community Engagement or Senior Associate Dean to encourage that mindset, and also mindset that, you know, in the team, you have to be a little bit selfless, meaning that don't worry about the credit. Let's get the team done and then you win. When you win, everybody wins. And as you know, David, I like team because I'm a huge proponent of team games like Packers, as you most probably know. And I used to play cricket a lot when I was young. I was a cricket captain. I learned lots of leadership skill when I was cricket captain. And you have to build a team in a way and really lead in a team in a way. You can have one or two superstars, but if you don't work in a team fashion, you actually lose many times. A superstar can take you so far. Most of the time, good team wins. So that happens in many sports. It is, to me, community engagement is a team sport, if you like, to say that way. Because I, just by myself, I cannot do community engagement. I need community partners. I need my academic partners. Every project we have, just think about how many people are involved, even in a small nucleus all the way to the larger group. So when you have that many people, that many pieces, that many community partners, if you do not think in a very different way in terms of let's create a winning team, let's create a positive team and take it, everybody contributes to their role. Offensive side has a different role than the defensive side in the Packers or the football game. But you cannot win the game without having both sides being good. So those are the kind of rhythm I have, and I've been doing it for years. So that is more my academic, my personal life. You know, I have a wife and kid I love to death. And as much as possible, I give them time. And I hope I can give more time in the future. But I keep that part also very close to me, very important to me. Plus, I have lots of friends, and brothers, sisters. We keep connected. I have most probably family in every continent, some relatives. So I keep those relationships also going in some way.
Thank you, Dr. Ahmed. Dr. Ahmed, I have one last question for you. And this wasn't on our list, but what gives you hope for the future?
If you're talking about community engagement, though?
You know, I think I'll let you go any direction you want with this, sir.
Well, I think, let me start with the community engagement. I think in 30 years ago, community engagement was not in existence. Now it is here. Many medical schools are doing it. Not all of them are doing exactly perfectly, but nobody's perfect. Medical college also has a significant change. I have a tremendous number of leaders who knows how to do community engagement in the medical college, and they are better than anybody else I know, nationally or internationally. So those gives me tremendous hope in terms of community engagement. Other pieces, more as a human being, as a physician, is I do talk about that why we are 37, 38 in the world. And we do not take it seriously. But by the way, if I can tell you a very quick short story. Mm-hmm. I wrote a paper, a short story kind of paper, and published in a British journal. That was, I mentioned to them, I wrote it that I asked many people this question: where do you think America is in terms of health outcome in the world? That was many years ago. That time, I believe we were 36 or something. So most people actually didn't know. I'm talking about academic people. Few people knew, but most of them were like a 10, 12, 11, those kind of numbers they're giving. So when I told them the real number, most people were also surprised. They didn't think that we are that bad. So I wrote a paper saying that, you know, if I ask everyone in the Olympics, where are we? If we know that in Olympics, we are always number one or sometime number two. And I think if somebody said in Olympics, we are number 36, I think next day, everybody will be up in arms, politicians and the Washington, they will take it so seriously that we have to be number one. We are the number one. But nobody takes seriously when we say the health wise, we are 36, 37, sometimes 38. And we spend more money than anything else. And we do not like to look at the underlying reasons. We don't want to address it. So the reason I'm saying that is when you say, what is the hopeful message? I feel like as we are getting to know many people, more than just few, that the importance of health disparity, addressing health disparity, improving health equity, addressing economic disparity, addressing social determinants of health, seriously addressing racism. If this is becoming a part of our language and part of interest, my hope is we'll start doing something positive. It can take many years, but if we do it, I can see many years from now, we'll say, you know what, we did something right. And America is actually number one in health outcome, not 37. So that's my hope.
Right on. Anything else you want to tell us today, Dr. Ahmed?
So I'd like to thank you, David. It was wonderful chatting with you. We talk a lot, and I know you for a long time, and I always appreciated your leadership, being a wonderful community engaged researcher and a wonderful human being. So I thank you for doing that. And again, I hope some people get to listen to it and they connect with us. So this is a journey. It is a continuous journey for all of us, and there is no ending to this journey for any of us. So I thank you, everyone.
Wonderful. You know, I lied. I got one more question for you, sir. It's my show. I can, you know, ask the question. Okay.
I'll do it.
Prediction for the Packers this year. What's the record going to be, sir?
Oh, goodness. You put me. My dream is different than what it could be. But so far, we are 2-0.
Yes.
And that is wonderful. So I am always hopeful for Packers. And so I would say we'll win at least 12. And
okay.
we'll go to playoff.
Okay.
Beyond that, I cannot tell. I want to win the Super Bowl again, but we are going to playoff.
Well, you heard it here first. The Packers are going to go to the playoffs because Dr. Ahmed, the big fan, because that is how he spends his Sundays.
You're right.
Dr. Syed Ahmed, you are a joy and a pleasure, and I learn something new every time I'm around you. Thank you for coming on the show today, and thank you for your wisdom and your connection to community engagement, and here's to the next 30 years of community engagement, sir.
Thank you, David. Take care.
You're welcome. Wow, what a conversation that we had with Dr. Ahmed today. You know, he talked about a lot of things that I want to encapsulate at the back end here. I think the big thing he talked about was the idea of the social aspects of community engagement. Community engagement is something not that you do alone, but it is built around that, the going out and engaging with the partners. And he talked about social determinants of health, those things, where we live and how it impacts our health. But he also spoke of the social values and the need for us to understand where people are coming from so we can better connect with and support. You know, community engagement is not without its challenges. I know this personally, and Dr. Ahmed mentioned it as well. But it's that idea of when we can engage the community in a way that brings us closer together, we make progress on the health of our community. I thought his example around the type 2 diabetes and health and what medicine can do to better understand where people can come from. And something as simple as having enough food so you can take your medicine was a really poignant example of that. He talked about the idea of building capacity around for the community as well as for the academic. And too oftentimes with our degrees, we want to tell the community what to do, but we really, at many times, we need to listen because the community has expertise. It's not the same as ours, but it it is still expertise. I am hopeful that the things that he talked about had meaning for you today, and that I hope you enjoyed the show. And if you want to hear more, we hope that you'll subscribe to the show. You'll leave us a comment and you'll share this on your social media platforms. This is the Days of Learning podcast. I'm your host, David Nelson, and I want to thank you for joining us today. Continued good health to you and to yours, and blessings to all.